Welcome to Citywide Medical Grand Rounds today, which is June 22nd. St. Joseph Healthcare Hamilton is the host site today, and I'm Dr. Madeline Verhovsek, the Chief of Medicine. Next slide, please. And we'll bring up the next slide. So we'll start with land acknowledgement today. And we acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide, please. I'm very excited to have our presenter here today. We have Dr. Amber Molnar, who is one of our nephrologists here at St. Joe's, and she will be presenting on the topic of treating lupus nephritis beyond standard induction. And co-hosting with me today is Dr. Anna Matthew, who is our head of service for nephrology at St. Joe's. And I'm going to hand things over to Dr. Matthew to tell us more about our speaker.
Thank you so much, Dr. Verhovsek. So it's my great pleasure to introduce my colleague, Dr. Amber Molnar. She's an assistant professor with the Department of Medicine, Division of Nephrology at McMaster University, and she holds a cross appointment with the Department of Health Research Methods, Evidence and Impact. She completed her nephrology and clinical research training at the University of Ottawa in 2015, and she joined our division of nephrology at McMaster shortly thereafter. She's an adjunct scientist as well at ICS, and in this role, she uses large provincial administrative healthcare databases to answer research questions pertinent to patients with kidney disease. She has a particular interest in chronic kidney disease care, in hemodialysis, and in glomerulonephritis. And on that note, I'll hand it over here to Dr. Molnar. Thank you so much.
So thank you, Dr. Matthew, for that kind introduction. These are my conflicts of interest. I have just some grant and research support to declare. This is the question that informed these rounds. So what do you do when a patient with lupus nephritis does not respond to induction therapy? And I'll address the following objectives. So I'll first discuss how and when treatment response for lupus nephritis is determined, define refractory lupus nephritis or a less than optimal treatment response. I'll discuss the causes of poor treatment response. And then finally, I'll summarize the evidence and treatment approach for refractory lupus nephritis. So I'll start with a case. This is a 33-year-old woman who has known lupus, who underwent a kidney biopsy due to the presence of proteinuria. And her kidney biopsy showed class 3, which is focal proliferative lupus nephritis, and also class 5, which is membranous. These are her lupus serology. Her complement level was 0.77 with a normal C4. Her creatinine was normal, and she had nephrotic range proteinuria at 7 grams per day with a low serum albumin. So she had nephrotic syndrome. For her lupus nephritis, she was started on prednisone and MMF induction. She was also already on hydroxychloroquine. She did, however, have some issues with adherence to this regimen. She was forgetting the evening dose occasionally. And there were also some delays in up titration of her dose of MMF due to concerns about side effects. 6 months following the start of this induction, her creatinine still remained stable. However, she still had nephrotic range proteinuria. And her serum albumin was also still low. Her complements had now normalized. She also had some issues with hypertension and weight gain. So in terms of lupus nephritis, we know that in patients with lupus, the reported lifetime incidence of nephritis is 20 to 60%. And the main clinical markers that we use to assess treatment response are kidney function, which we estimate using a serum creatinine, and proteinuria, which we measure using typically a 24-hour urine for protein, or a urine protein to creatinine ratio, and also a urine albumin to creatinine ratio. We also look at hematuria determined with urinalysis and microscopy. And then a kidney biopsy is very important for diagnosis and determining the initial class of lupus nephritis. However, the role in monitoring treatment response and determining remission is a little less well established. So if we look at this slide summarizes some of the landmark trials in lupus nephritis and the various ways in which these trials determined their primary outcome of renal response and also their definition of complete remission and when this was determined. You can see that there is some variation across the trials, but overall, all of them incorporate a combination of a reduction in proteinuria, stabilization or reduction in serum creatinine, and some have defined also a complete remission as an inactive urinary sediment along with the creatinine and proteinuria criteria. So the ELMS trial, this compared MMF or CALIBRATE versus cyclophosphamide, and this showed no significant difference between these two regimens. The EuroLupus trial compared high dose versus low dose IV cyclophosphamide and showed no significant difference. And then most recently, we had the BLISS trial, which looked at Belimumab, which is an anti-B cell therapy versus placebo, in addition to standard care, which would be cyclophosphamide or MMF. And so MMF and cyclophosphamide are typical first-line induction therapies for lupus. And if we look at expected response rates, so these are the primary outcomes within these trials. So at 6 months in the ELMS trial, there was just over 50% of patients in each arm had achieved the primary response rate or primary outcome. In EuroLupus, high dose arm, 54%, and in the low dose arm, 71%. So you can see that this is definitely well below 100% response rate. And so there will be a significant number of patients who do not achieve renal response after 6 months of therapy. So in terms of monitoring treatment response, this is a secondary analysis of that ELMS trial that compared CellCept and IV cyclophosphamide. And here they looked at some markers at 8 weeks and whether or not they predicted a renal response at 6 months. And they found that a reduction in proteinuria at 8 weeks, and reduction in proteinuria was defined here as a decrease of 25% or more. This was significantly predictive of renal response, as was normalization of the C3 and the C4. A reduction in anti-double-stranded DNA was not significantly predictive. This is an analysis, it's a secondary analysis of the EuroLupus trial. So this trial, again, comparing a high-dose IV cyclophosphamide versus low-dose IV cyclophosphamide. And they looked at long-term kidney outcomes with a median follow-up of 6 years. And they found that the serum creatinine at 6 months being decreased was very strongly associated with a good long-term renal outcome, as was a 24-hour urine protein less than 1 gram at 6 months. Again, secondary analysis of a lupus nephritis trial comparing plasmapheresis to no plasmapheresis in addition to standard induction therapy. And here they looked at a reduction in proteinuria of greater than or equal to 50% at 6 months, and the association of this with long-term kidney survival. And they found that this reduction in proteinuria at 6 months was highly associated with better long-term kidney outcomes. Another similar secondary analysis from this plasmapheresis trial, where they also looked at kidney survival, so the absence of end-stage kidney disease, and they looked at patients who achieved a complete remission or partial remission or no remission within the trial. And those with a complete remission obviously had the best kidney outcome, but a partial remission was still important and was significantly associated with a better kidney outcome. Again, the Euro-Lupus trial, so this is the long-term follow-up data from that, where they did have quite long follow-up of 7 years. And they looked at a number of predictors of good long-term kidney function at 12 months. And they found that this outcome, or this predictor at 12 months of proteinuria less than 0.8 grams per day, what probably had the best combination of sensitivity, specificity, and positive predictive value in terms of predicting a good long-term kidney function. And they define this good long-term kidney function by serum creatinine less than or equal to 88 micromoles per liter. When they looked at urinary RBCs, which is often incorporated into the complete response criteria for some of the trials, they found that this actually did not perform all that well in terms of predicting a good long-term kidney function with a low sensitivity and specificity. When they added in serum creatinine to the proteinuria predictor of less than 0.8 grams per day at 12 months, there was not a meaningful improvement in terms of the predictive ability. So this low proteinuria of less than 0.8 grams per day at 12 months does seem to be a really important factor to look at in terms of predicting good long-term kidney outcomes. This just highlights that same concept in a figure. This is the ROC curve from that study, and just showing that the proteinuria less than or around 0.8 grams per day at 12 months has the best combination of sensitivity and specificity for predicting good long-term renal outcome. So from that, we can see that monitoring the trend in proteinuria, looking for a reduction in that variable, and also the trend in the serum creatinine are very important. And this should be monitored frequently early on during induction therapy to determine the treatment response. And so how do we define refractory lupus nephritis or a poor treatment response? And these are the criteria taken from 2 of the guidelines. So here on the top are the European guidelines, and they state that a failure to improve within 3 to 4 months, or to achieve a partial remission within 12 months or complete remission within 2 years, should be considered concerning and a consideration for changing therapy. The KDIGO guidelines, so these are the Kidney Disease International guidelines, and these were recently updated for glomerulonephritis within the last couple of years. And here they define a complete response for lupus nephritis as this reduction in proteinuria to less than 50 milligrams per day, and also stabilization of kidney function. And this is within 6 to 12 months of starting therapy. But they do emphasize that it can take more than 12 months to achieve a complete response. So it does take a long time to determine how exactly a patient will respond to their therapy. Partial response is a reduction in proteinuria of at least 50% and not nephrotic range, and stabilization of kidney function. They define no kidney response as a failure to achieve either partial or complete response within 6 to 12 months of therapy. So once we've established that someone is having a less than optimal or poor response to their induction therapy, what are some things we need to look at in terms of determining the cause? So first, you want to rule out any potential non-adherence to their immunosuppression therapy. So unfortunately, in patients with lupus, non-adherence is a significant concern and should always be explored as a contributor to poor response. So these figures are taken from a study that used Medicaid data from the United States. And they were looking at patients with lupus and examined their prescription dispensing data over time for both azathioprine and mycophenolate, which are both commonly used to treat lupus. And this black line up here shows patients who had a persistently adherent pattern to their prescription dispensing. These green and blue lines show patients that were variably adherent, and the red line is patients who had a persistently non-adherent pattern. And you can see that both patients taking azathioprine and mycophenolate, a large percentage of them fell into this persistently non-adherent category. And overall, when you look at various studies that have examined adherence or non-adherence in lupus, the rates are quite variable, but range between 3 to 76% across the studies. So you do always have to consider this as a potential cause of poor response to treatment. And this is taken from a qualitative study that examined contributors to non-adherence, and they lumped them into these 4 main themes, with one being patient-related. So patients were commenting on things like pill burden. So typically they are introduced to a large number of new pills at the time that they're started on their induction regimen. They may just simply be forgetting. They may have uncertainty about the benefit of these medications and have difficulty accepting their chronic illness. Healthcare related was also an important theme. So the patients commented on a lack of or poor communication from their physician or healthcare providers and having possibly mistrust with their healthcare providers. Medication related, so side effects are very important, so always screening for side effects at clinic visits. And then this issue of they're not noticing a meaningful immediate improvement with starting the medications. And then lastly, disease related was another big theme. So lupus can really vary in terms of the clinical symptoms. In particular, some forms of lupus nephritis, they may have very little in terms of actual clinical symptoms. And so they may think, oh, I feel fine. My disease is mild. And that may provide less incentive in terms of taking the pills regularly. If we look at some strategies to determine non-adherence, so we're very fortunate here at St. Joe's. We have a multidisciplinary glomerulonephritis clinic where we have a glomerulonephritis or renal pharmacist who really helps us out in terms of sorting out medication non-adherence and takes a very careful history in regards to this. So definitely spending some time with the patient is very important. Reviewing their pharmacy records, ensuring that they're filling their prescriptions on time, taking a detailed history with the patient to determine if there is any non-adherence, and looking into things like blister packs. You can also use drug levels in the clinic. Really the only drug level that we are routinely ordering is for calcineurin inhibitors if they are taking that. So for example, tacrolimus or cyclosporin. So speaking of drug levels, I thought this was an interesting study where they took patients with lupus and they looked at a number of different methods of determining adherence to their medication regimens. So in this study, they were measuring hydroxychloroquine drug levels. We don't do this in the clinic, but almost all of our patients with lupus are on hydroxychloroquine. And then they also administered a questionnaire to patients that measures drug adherence, and then had the physician complete a visual analog scale where they were rating whether or not they thought the patient was adherent to their medication regimen. And they looked at the correlation between drug levels and the questionnaire and physician assessment. And a Spearman correlation coefficient of 1 is considered very high or perfect correlation. And you can see that the correlation coefficients are fairly low here, ranging from 0.37 here to 0.19. So there wasn't very good correlation between these different measures of adherence. And overall, they found that about a third were considered non-adherent to their hydroxychloroquine treatment by at least one of the criteria, whether it be drug levels or questionnaires, and only 10% by both methods. And that 43% of the non-adherent patients by drug level would have been classified as adherent based on questionnaire. So this highlights to me that by our usual methods in the clinic, where we are interviewing patients and largely relying on the history that they provide to us and as well the prescription dispensing data, we're probably missing a lot of non-adherence that is occurring. So in terms of some strategies to address non-adherence, I think this likely needs a multi-component intervention and an interdisciplinary team. So as I said, we're very fortunate that we do have this glomerulonephritis clinic where we have available to us specialized nurses, pharmacists, and also a social worker if needed to possibly help with some funding issues. Really developing a strong communication and building trust with the patient. Interim phone follow-up check-ins might be helpful, addressing any financial barriers to medications, trying as much as possible to simplify the medication regimen and the frequency of administration. Even some of our young patients are on blister packs because they have struggled so much with the complexity of the medication regimen. And then if patients are really struggling with the oral induction regimen, so for example, taking prednisone and CALIBRATE, you might consider IV cyclophosphamide, where then you can really accurately determine adherence because they're having to come to the hospital to get the injections. And I think asking about side effects is critically important. Patients won't necessarily always immediately volunteer these, but if they are experiencing side effects, this is definitely going to affect their adherence. So in terms of other causes of poor treatment response, we've spoken about non-adherence. The other issue is potentially insufficient dosing of their current therapy. So for example, patients who are taking CALIBRATE, sometimes they might be experiencing GI symptoms from the medication that is limiting your ability to get to the target dose. So in that case, you might consider something like what we would call multi-target therapy, where you would add in a calcineurin inhibitor, and I'll speak more about this later on in the talk. You may want to consider other contributing diagnoses. So for example, thrombotic microangiopathy, which can be associated with lupus. So in this case, you might consider repeating the kidney biopsy. For the ongoing presence of proteinuria, especially if it's been quite a while since their kidney biopsy, if you're looking at a year or two down the road, you need to consider that there might be some chronic damage that is occurring, and that can also contribute to proteinuria. And lastly, which I will spend the bulk of the talk focusing on, is this refractory to current induction therapy. So if you have gone through that list and ruled out all the other causes and you are suspicious or convinced that the patient is actually truly failing their current induction regimen, the first thing to consider or try is probably to switch to another first-line standard therapy. So if they're getting IV cyclophosphamide, you would switch to MMF or CALIBRATE, and if they're on CALIBRATE, you would switch to IV cyclophosphamide. So in terms of the data or the evidence to support switching between these initial standard induction regimens, so this is a study which looked at patients who have refractory or relapsing lupus nephritis. And these patients were all switched to MMF or CALIBRATE to treat their lupus nephritis. You can see that they were on a number of different prior treatment regimens for lupus. Most had previously been on cyclophosphamide. There was a mixture of different classes of lupus nephritis, so class 3, focal proliferative, and class 4, diffuse proliferative, with a small number having class 5 or membranous. Most of the patients had fairly preserved EGFR, and most had nephrotic range proteinuria. So when they looked at their treatment response over time, again, this is not a trial. This is, they were just switching all the patients to MMF or CALIBRATE. Many of the patients had a complete or partial response within 3 months. And over 60% of the patients had a response at 6 months, and then a large number again at 12 months. And there were a few others that continued to have a response at 24 months. But when you look at the number of new responders, so it's really during this initial period where there was a new response that was seen. So over the period of 3 to 6 months was where most people were responding to the therapy. And there were a small number that continued to show a response at 12 to 24 months, but really beyond 24 months, there was very little new responses. So that's the first strategy, to switch to another first-line therapy. The second strategy is to add or switch to a calcineurin inhibitor, so tacrolimus or cyclosporin typically. So this is the data for tacrolimus. This table is taken from a meta-analysis, and all of these studies are done not examining refractory lupus nephritis, but examining the addition of tacrolimus as primary induction therapy. And they've either compared tacrolimus to IV cyclophosphamide or MMF, or they've looked at tacrolimus in addition to other standard induction therapy compared to IV cyclophosphamide. So probably the biggest study here to highlight is a trial that was done in China. It's the largest trial, including 181 patients in each arm. And this trial examined multi-target therapy, so tacrolimus plus CALIBRATE compared to IV cyclophosphamide, and we'll go through this trial in further detail. So this is the forest plot from that meta-analysis, and they compared the various therapy combinations and looking at complete or partial remission in the studies and pooled those results together. So for tacrolimus compared to IV cyclophosphamide, there does appear that to be this favoring of tacrolimus. IV cyclophosphamide compared to tacrolimus plus MMF, there does appear to be a favoring of this multi-target therapy, largely driven by this Chinese trial that I will speak about more. And then when looking at MMF compared to tacrolimus, there was no significant difference. So this is the multi-target trial that compared MMF plus tacrolimus versus IV cyclophosphamide. They had fixed dosing of MMF of 500 milligrams BID and then fixed dosing of tacrolimus in the multi-target arm. They had pretty typical patient demographics within the trial for a lupus trial, mostly women, a mean age of approximately 30 years, and then they included a variety of classes of lupus nephritis. When they looked at the probability of achieving a complete or partial remission, this was more likely in patients who received the multi-target therapy compared to IV cyclophosphamide. However, there was a signal for an increased risk of adverse events, most importantly infectious events, in the multi-target therapy group. So that's the data for tacrolimus as primary induction therapy, but what about in the setting specifically of refractory lupus nephritis? So it's all observational. This is a case series that included patients who had failed to respond to induction therapy with IV cyclophosphamide after at least 6 months. All these patients had class 4 or diffuse proliferative lupus nephritis. And here they looked at the reduction in proteinuria over time And overall, they found that there was a 78% response rate looking at that criteria. And they also did comment that patient number 1 here, when they extended the follow-up, this patient did experience a significant reduction in proteinuria. This is the change in serum creatinine over time for all of these patients. So all showed stable serum creatinine, except for patient number 3, who was the same patient that did not show any response in proteinuria. So what about cyclosporin, which is another calcineurin inhibitor that we commonly use in terms of cyclosporin data for refractory lupus nephritis? This is, again, observational data taken from a lupus registry where they enrolled patients who had either induction-resistant lupus nephritis or lupus nephritis that was flaring. And they treated these patients with cyclosporin and prednisone with or without MMF for at least 12 months. And so this table highlights how many patients showed a response to cyclosporin and prednisone, or cyclosporin plus MMF and prednisone. So I'll draw your attention to the urine protein to creatinine ratio. Here at baseline, it was 3.6 grams, so nephrotic range. And by 6 months, this had dramatically reduced to 0.4 grams, and at 12 months, 0.2 grams. So a significant reduction in proteinuria, and this was seen with both just cyclosporin and then cyclosporin and MMF. eGFR also was stable over time. So overall, 90% had achieved complete remission and 5% had achieved partial remission after 12 months of the therapy. Again, though, observational data. This is not a trial. And then there's the newest calcineurin inhibitor that's available called Voclosporin. And there have been 2 key trials published relatively recently examining voclosporin for the treatment of lupus nephritis, so the AURA-LV and AURORA-1 trials. And in this paper, they pooled together the results from these 2 trials. And so for these trials, they were looking at MMF plus a low-dose rapidly tapered prednisone. And then in addition, patients could receive voclosporin or placebo. Similar demographics to and characteristics to most other lupus trials, with the mean age of 30, most being women. They enrolled a variety of different races and different classes of lupus nephritis. So when they looked at the probability of a 50% reduction in the urine protein to creatinine ratio over time, patients in the voclosporin arm had a much higher rate of this compared to control. And they also broke it down by a number of different subgroups, including race, region, and class of lupus nephritis, and also baseline proteinuria and eGFR. And there did not really appear to be any striking differences across these different subgroups, but all were really overall favoring voclosporin. If we look at the absolute responses in terms of complete renal response at 52 weeks in the Aurora trial, 41% in the voclosporin arm and 23% in placebo. In the AURA-LV at 24 weeks, it was about 30% in voclosporin and 19% in the placebo arm. And the incidence of adverse events when these 2 trials were placed together overall was similar. So to summarize the calcineurin inhibitor data and put this into a real world context in Ontario in terms of drug accessibility. So we do have increasing evidence that calcineurin inhibitors are effective for induction therapy in lupus. And before, most of this data was limited to Asian populations, but now we have data in more diverse populations that calcineurin inhibitors are effective. We do have limited direct evidence for refractory lupus nephritis. If we look at the three main calcineurin inhibitors, so tacrolimus, cyclosporin, and voclosporin, tacrolimus is easily available if the patient has private insurance. If they do not and they have provincial insurance, you do have to file an EAP application, and you definitely have to do drug level monitoring, so trough levels. With cyclosporin, this is actually routinely available through the Ontario Drug Benefit Plan, so you can just write a prescription and it will be covered. Again, they have to do drug monitoring. Voclosporin is not yet available. It is quite expensive. One of the key benefits of this is that drug level monitoring is not required. So we've covered adding or switching to a calcineurin inhibitor. The next thing to consider would be a B-cell depleting agent. So if we look at the first agent that I'll talk about is Rituximab in lupus nephritis, and this table is taken from the Molnar trial that looked at Rituximab being added to primary induction therapy for lupus nephritis. And the standard induction that was used was prednisone plus MMF. And they then randomized patients to also receive Rituximab versus placebo. Again, mean age around 30 years of age. Most were women, variety of different races and different classes of lupus nephritis. The mean urine protein to creatinine ratio was around 4, so nephrotic range proteinuria, and preserved eGFR with a mean eGFR of around 90. When we look at the primary outcome that looked at renal response, this was no different in between the two groups. So overall, this was a negative trial. You do see in the bottom here some secondary endpoints that they examined. So at week 78, complete or partial proteinuria response. This was higher in the Rituximab arm, and switching to cyclophosphamide, which could be an indication of failing the standard induction at both week 52 and week 78 was higher in the placebo arm. But again, the primary outcome was negative, and this was overall deemed to be a negative trial for the use of Rituximab for primary induction in lupus nephritis. So what about in the setting of refractory lupus nephritis? So this is a meta-analysis that pooled together the literature on this topic. It's all observational, so you have cohort studies, case series, and some case reports, so fairly low quality data. The studies included a variety of different classes of lupus nephritis, but most patients had class 4, diffuse proliferative, and they had received a variety of different immunosuppressive therapies. When they pooled together the overall data, 26% of patients were non-responders, 40% had a complete kidney response, and 34% a partial response. They did also look at things by breaking down patients into the various classes of lupus nephritis included across the studies. And the authors thought that there was possibly an indication that class 5 lupus nephritis, which is membranous, which would primarily manifest as proteinuria, that there was maybe a higher non-responder rate in this group at 33%. So to summarize the Rituximab data and drug accessibility of Rituximab, so the Molnar trial did not show any added benefit for Rituximab as induction therapy in lupus nephritis, but we have some observational data which suggests the benefit of Rituximab for refractory lupus nephritis. And we do have the ability to access Rituximab for lupus nephritis by filing an EAP application. So what about Belimumab, which is a newer B-cell therapy? And this is the table 1 from the BLISS trial. And this looked at the addition of belimumab versus placebo to standard induction therapy in patients with lupus nephritis. And again, similar characteristics to other trials, with most being women, mean age of around 30. About 50% of patients were Asian, and there were different classes of lupus nephritis included. So their primary endpoint was what they called this primary efficacy renal response, which was a combination of proteinuria reduction, stabilization of creatinine, and this was determined at week 104. So they did have a fairly long follow-up time. And they found a difference of 11 percentage points with a better response in the belimumab arm, and this was statistically significant. This is a secondary analysis that was recently published of the BLISS trial, where they looked at this primary efficacy renal response and complete renal response across the different classes of lupus nephritis that were included. They found that there was no difference in the various classes, except for maybe class 5. But again, a relatively small number of patients with isolated class 5 lupus nephritis were included in this trial. So all the classes up here were all favoring the addition of belimumab to standard therapy. This was an interesting secondary analysis where they broke it down into the 2 subgroups of low proteinuria versus high proteinuria. High proteinuria was defined by more than 3 grams per day. And it was interesting in that there does appear to be a differential response by these 2 subgroups. So those with high proteinuria did not seem to gain any benefit from the use of belimumab. So what about belimumab specifically for refractory lupus nephritis? So the BLISS trial was looking at the addition of belimumab for primary induction therapy. So here, this was called the CALIBRATE trial, which looked at the addition of belimumab to a combination of prednisone, IV cyclophosphamide, and Rituximab. And this was specifically focusing on patients who had refractory or relapsing lupus nephritis. Mean age of a little over 30 years. Most were women, a variety of different races, and also different classes of lupus nephritis. There were none with isolated class 5 lupus nephritis. Mean proteinuria was more than 3 grams per day, so nephrotic. And the mean eGFR was around 90. This trial was actually primarily designed to look at safety endpoints for the 2 types of interventions, and they determined that there was no significant difference in the Rituximab cyclophosphamide arm compared to the Rituximab cyclophosphamide and belimumab arm. When they looked at the efficacy endpoints, so complete renal response versus partial response, they found that there was no difference across the 2 intervention arms. But again, this trial was not primarily designed to look at efficacy. So to summarize the belimumab and drug accessibility data for this, so there is evidence to support a benefit as belimumab being an add-on therapy for primary induction. It might be more effective in the setting of lower proteinuria. There's no direct evidence for the treatment of refractory lupus nephritis when it comes to belimumab. This drug is not terribly easily accessible in Ontario, so there is some funding support available through the pharmaceutical company, and also some patients, you can access this through their private insurance, but overall, if they do not have private insurance, this medication is really cost prohibitive and there's limited accessibility. When we look at other potential therapies, so there are other therapies in very dire situations that can be considered, but the data for these are quite limited. IVIG possibly if infection is also coexisting and of concern. Plasma exchange, sometimes anti-complement therapy with eculizumab, but again, the data are quite limited. So to summarize overall, lupus nephritis really is a difficult disease to treat, and you do need to do frequent reassessments of treatment response early on in the induction period, paying attention to frequent measurements of the serum creatinine and also repeated measurements of proteinuria, looking at trends in proteinuria over time, which are very important in terms of predicting treatment response and overall long-term good kidney outcomes. If you do not see any improvement within the first 2 to 3 months, the reasons for this really need to be thoroughly explored. And if you do determine that there is true failure to the primary induction therapy, then you should first consider switching to alternate standard induction therapy, and then consider adding on a calcineurin inhibitor, Belimumab or Rituximab. And lastly, in order to better study this issue of refractory lupus nephritis and how best to treat it, a clear consensus definition for this is really needed. This is just taken from the kidney disease or the KDIGO, Kidney International Guidelines, and summarizing their overall approach to a patient who is having a less than optimal response to initial induction therapy. So again, verifying adherence is very important first. You may choose, if available, to measure drug levels to confirm adherence. You might consider repeating the kidney biopsy if you have a concern for an alternative diagnosis that would be associated with lupus. You would first consider switching to one of the alternative first-line regimens. And then lastly, you would consider adding in or switching to one of these other therapies. So just to end, I'll summarize what happened with the case that I presented at the beginning. So this 33-year-old woman who had biopsy-proven lupus nephritis and who was having some issues with adherence and also with some side effects that were delaying up titration of her CellCept. And you'll recall 6 months post-induction, her creatinine was still normal, but she still had nephrotic range proteinuria. She also had issues with hypertension and weight gain, which could be exacerbating the proteinuria. So we optimized her hypertension control, up-titrated her RAS blockade. Ultimately, she was switched to IV cyclophosphamide. This unfortunately did not result in meaningful improvement, so she still had nephrotic range proteinuria. Creatinine is maybe starting to drift up a little bit. And then once she was switched back to her MMF for maintenance after completing the cyclophosphamide IV, after a period of time of a lack of improvement in proteinuria, cyclosporin was added on because this is what was all that she had coverage for. And then 12 months after that, her creatinine is maybe starting to drift up a bit. She still has nephrotic range proteinuria. However, serum albumin has now normalized. So we went ahead and repeated her kidney biopsy. She is starting to develop some chronic changes. So she has focal sclerosis and some mild interstitial fibrosis and tubular atrophy. So this will contribute to somewhat to ongoing proteinuria. But she still also had evidence of active lupus nephritis, and she had now class switched a bit. She had diffuse proliferative and membranous. So an EAP application was filed to start her on Rituximab. And that's the end, so I'm happy to take any questions.
Thank you very much, Dr. Molnar, for an excellent presentation on a complex condition that fortunately seems to have a very good variety of treatments for patients at all levels of refractoriness. So we have one question in the Q&A. I'll invite folks, if you have any other questions, either to enter in the Q&A or if anyone would like to ask their question. And then we can, I'll arrange for you to be unmuted. So I'll read the first question here, which is from Dr. Greg Kernu. Can you comment on evidence of blister packs? To my understanding, no good RCT evidence and found for many patients it allows them to be less involved in their care. Interesting perspective. Any thoughts on that?
Yeah, so with respect to the strategies that I presented for increasing adherence, very correct comment that there is no good RCT data for that. It's not really a strictly evidence-based approach. This is more just on commenting on best practices and things that we've maybe found anecdotally that might work, but definitely a multi-pronged approach is needed. I guess the comment about patients being less involved in their care is a fair one. I have found, though, that even with some of my young patients in their 20s, blister packing has helped them. It's really simplified things for them, and it allows us an easy way as well to track if they're actually taking things appropriately when they bring their blister packs into the clinic.
Great.
Thanks,
Thank
Dr.
you.
Molnar.
Yeah, and you're fortunate, as you said, to have the pharmacists on your team and that interdisciplinary team there assisting with kind of a holistic assessment of what the barriers are to the patient adherence. I really appreciated that. I think it transcends lupus nephritis into other chronic conditions as well. There's a comment here or question here from Dr. Holbrook, maybe related to the blister packs. The problem in assessing and dealing with medication adherence is that there is no good diagnostic standard for most drugs. Yeah. As you had pointed out in that one study, right, where they had kind of the 3 different definitions of adherence or non-adherence. Did you have any further comments reflecting on Dr. Holbrook's comment there?
Yeah, no, I think that's a very accurate point. Drug adherence is something that we really struggle with. I think it's a really difficult thing to accurately determine and measure.
Maybe I can ask a question while others are pondering. So, Dr. Molnar, that was excellent. You know, it's a very complicated literature. It must be frustrating for you as a practitioner in this area that there's not a lot of high quality RCT data, especially as you get into the more resistant or refractory type of disease. But I appreciated you walking through us all the observational studies and case series. And while there is a lot of options in terms of drugs, you know, in the patients that I'm not an expert on this, but the patients that I've co-managed with you or managed, drug access, as you had highlighted, is a substantial, huge issue. And I was wondering if you'd comment, you know, when you talk to your colleagues across the country, are there any differences in the different provinces? Is Ontario especially terrible in getting coverage? You know, maybe you could, and, you know, CADIF had these recent recommendations for Belimumab, not, you know, outside of only for induction. You know, so there's a lot of competing issues here. Maybe you could just comment on that and how you navigate that.
Yeah, I'm not aware of any significant differences across the provinces. There's definitely, I think, country differences for sure in terms of accessibility in the US versus Canada. And from what I've seen, it does seem like in the US they're adopting these newer therapies in a lot more of an aggressive way than maybe we have in Canada. Certainly, when it comes to Belimumab, our access to it is really very limited, and I don't know if that will improve. It is a bit unfortunate. Sometimes you have younger patients who are really hesitant to take IV cyclophosphamide, younger women in particular, and you maybe want to try that therapy for them, but they don't have private drug coverage, and then it's just really not an option because it's not affordable.
Yeah, because I was wondering whether if funding was in an ideal setting where funding was not an issue, if our standard initial induction treatments would perhaps be different, because the nice RCT data you presented on multi-target treatment and Voclosporin, those are all for induction therapies. And would that actually be different in Canada if there was, better access to these drugs?
Yeah, I think it possibly could be different, but we don't have access. But I would say our pharmacist, this is where our pharmacist is just indispensable. She does a really amazing job in assisting us and all these the applications that need to be filed for all the EAP applications and funding applications. She does a lot of work in advocating for our patients, and a lot of paperwork is involved.
Thank you so much. Always room for improvement in these spheres, and particularly challenging kind of situations that can arise from discrepancies in access to therapies across different geographies. So we hope that continues to evolve for you and your patients. And with that, I think we'll wrap things up for today and send around a huge virtual round of applause for Dr. Molnar, and thanks for coming and sharing your expertise today. Thank you to Dr. Matthew for co-hosting today. And just before we wrap up, I will remind everyone that next week will be HHS hosted rounds at the same time on June 29th, and that will be Dr. Jack Hirsch presenting on the evolution of anticoagulants. And thereafter, rounds will break through the months of July and August while everyone hopefully mixes in some work and much needed rest. So thanks again to our presenter, and I wish everyone a wonderful day. Take care.